teacher of teacher, Dr. Prajapati sir, is definitely uh, taking it forward in a very, very different, innovative way, very interesting way. Where that's why everybody, all of us, just join for this program. I wish you all the best for the happy learning and keep on grabbing a lot of take away or take home points from sir. This is the best thing what we can get today. Thank you very much.
Uh, I welcome Dr. Neelam Mohan, madam. Uh, I request madam to say a few words before we proceed for the today's class.
Thank you, Arif. I would request you to say a few words about yourself. So, who are you?
Dr. Arif is one of the faculties at BJ Medical College, Ahmedabad.
Very lovely meeting you,
He is
Arif.
very young, dynamic associate professor, and I will say conducting the whole session, managing very nicely. Madam, Dr. Arif Vora is, I will say, that person.
Thank you so much, Arif. It's indeed a pleasure to know you and to be invited by you.
Thank you, sir, for your kind words. So,
yes, because it's always nice to, introduce you also to everybody.
Yes.
Thank you so much. And I only hope I can give a little quiz to all of you today on this podium. And that quiz is, suppose anybody asks you, why should I join IAP? What are the benefits of IAP? So if you prepare an answers for this and give it to Prajapati, and the best person who prepares the answer will get an award from Dr. Neelam Mohan. And Prajapati will see whoever is attending today, not only in the beginning, but by the end of this also, all the people who have been attending, because to me, I don't want to sound prejudiced, but to me, it looks as if the life and world would have been incomplete for a pediatrician without IAP. But am I right? Am I wrong? So let us see what you all think, the advantages. Why should you be a member? Is it member just because you get a journal Indian Pediatric, or there is much more to it? What is the advantage of learning from colleagues, going to conferences, seeing digitally, DT Academy, and the continuous amount of website we keep posting, the continuous amount of the CMEs and the action plans we keep conducting, how we work in social, how we work in charity, how we work. So a brief of this group prepares and gives us in the next 48 hours. And so you will get a cash prize of 2,100 from me, and Prajapati, I don't know what he's going to give, but that's what I'll give. And Ruchira, being the boss of IAP, she will give much more than this in the form of a trophy and certificate too. So I will add on a little to Ruchira for that. And thank you so much for having me over. And kudos to you all. Happy learning. Be innovative. Think beyond the box. Just don't be the run of a mill. So that's the topic you all will deliberate and let me know. Good day and good learning. All those who joined late, suddenly there's a surge of 40 people. When I spoke, it was only 21. So I request Prajapati to announce this both in the center and in the end. Twice you should inform what I asked you. In 48 hours, they have to send you, and you send me the best candidate number. And we will ensure that what all I said, I've said.
Sure, we'll do.
Okay. Thank you so much, Arif Vora, for this opportunity too.
Yes, Dr. Arif, are you there? Dr. Arif?
Back
I
to
think,
you.
I think.
I think there was a little
good evening, sir. Without
In the
wasting time,
meantime,
you
sir,
can,
we have president-elect also
yes,
here.
Dr.
A
Singarvelu,
few
I
words
think.
from
no,
Yeah.
nothing,
him.
sir. Just
sorry, sir, there was some network issue.
Yeah,
no
we got
issue.
it. We
Thank you,
can't.
Arif.
So,
Thank you, Arif. No
thank you,
need
madam,
for.
for your kind words, and we'll definitely do it. And we'll get back to you, madam. I also welcome Dr. Singer Velu, sir, and I request him to say a few words before we proceed for this today's lecture.
Thank you, Dr. Arif, respected President Ilam and HSC Ruchira, Prajapati sir, and all the students who are in the Zoom and also in the Digi. Definitely, this is a flagship program of our IAP, which is going on for years. And this year, it is uniquely our Digi IAP is taking over. So, a lot of people will be watching it. Definitely, it is that too when Prajapati sir is there. Definitely, I did not stand before sides. I know his meticulous. Teaching and definitely all our PGs will be definitely benefited out of it. Without wasting much time, I don't want to stand before science. Wish you all a happy learning. Thank you, Arif, for a wonderful campaigning and other things. Over to you. Thank you.
Thank you, sir. So, with the permission of the chair, can we start the session? So I welcome our senior teacher, and I may say the teacher of the teacher, Dr. Baldev Prajapati, sir, to start our session. I
Yes.
also welcome today's presenter, Dr. Subhi Singhal. She is a third-year resident in MGM Medical College, Indore. And I also welcome her mentor, Dr. Anjali Bharani. She is associate professor at MGM Medical College, Indore. So I welcome all of you. Prajapati sir, it is over to you, and we can start the session.
Yes. I think before I ask Dr. Shubhi to share the PPT. Dr. Shubhi, wait for a minute. Respected our dynamic president, Dr. Neelam Mohan Madam, HSG, Dr. Ruchira Gupta, our president-elect, Dr. Sangarvelu, Arif, presenter, Dr. Shubhi, her mentor, Dr. Anjali, all your other faculties and the students. I think as Madam asked the others to respond, that what is your interest to be, I will say, member of the Indian Academy of Pediatrics. Before you go in the further, let me mention over here that presence of President, Secretary, and President-elect before the session starts, I think itself is the attraction, that how much they are committed. We understand that in spite of their, I will say, busy and other activities, so many other activities that hardly they will get the time. But still, because they feel that we are committed, their presence for these type of the academic sessions and to encourage the students and the teachers is certainly, I will say, besides all other attractions, it's a big attraction and it should be there. So I will really certainly pass on this remark to all the students and even the other young pediatricians. Thank you very much, madam, for your presence, both Dr. Neelam Mohan, Dr. Ruchira, and even Dr. Sangarvelu, and all others. As already I said that this is a mutual learning. Not only the students are learning, being teachers, all of us are learning. And I request all the students that, as madam said, make it, I will say, very live session, very interactive session. Each student should respond when I ask the question or we go for the analysis. Please don't hesitate. Don't feel that you are going to be wrong or your response may not be right. That should not be the hesitation. In the science, nobody is perfect, even the most senior people. On the contrary, all of us are learning. The only thing that once you remove that hesitation and very freely you interact, ask the questions, even put your, I will say, comments, your answers, responses, and with this interactive session, we can make it more, I will say, effective, attractive, and even the more learning. So I will say with this remark, I request Dr. Shubhangi to, the person who is going to present, you can share your PPT, Dr. Shubhi, on screen and start the history part. Dr. Shubhi, please. Dr. Shubhi, are you finding difficulty in sharing? Yeah. Okay, started. Good. Can you make it full screen?
You're muted, ma'am.
Yeah. Yes, you are muted.
Madam, on the bottom, there is a full screen window. Just click on that.
Good evening, sir.
The PPT bottom.
Dr. Shubhi, yeah.
Yes, sir.
You check there is a full screen window. Just click that.
Yes, sir.
Yeah, that one. Yeah, that one. That
Yeah,
one.
yeah, right, right.
No, 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 no.
Yeah,
Yeah,
I
that one.
think-
That one.
yeah.
Yeah, that one.
The cup-like
No, no, I mean
icon.
what?
Cup-like icon at the bottom.
So
Bef-
it's not happening.
I think you may click it sharply, then probably it should work.
Happening, sir. I'm clicking the icon, but it's not getting full
Okay,
screen.
okay, okay.
Are you on laptop or now PC? Are you on a laptop or a PC?
So I'm on a PC right now.
Okay, just
Like
press
PC,
F5.
PC.
PC, just press F5. F5. I think there is some connection issue.
Yes, sir.
Yeah, there we go.
Yeah, I think now it is
Happening.
at the full screen. Yes.
Continue to share.
Probably her connection is lost in between.
Yeah. Ma'am, can you just switch off your video? That will make
Yeah.
switch off your video.
Shubhi, I think if you switch off your video, then probably
Yes.
that
Share
connection
your
issues
screen.
will be less.
Share your screen and
ये
press
किसको
F5.
प्रॉब्लम हो रही है ये शुभी को अच्छा
Yeah, press F5.
Yes, I did that, but I don't know why it's not occurring.
Just press F5.
Yes, right. I did that also, sir. Sorry.
Like what happened? Like if you're not able to scroll the slides,
You're able to scroll the slides.
can you change the slides?
Or anyone else can share this in that group. Do you have anyone who can just share this or just send it to me? I can share it for you.
I'm just trying to get one. Sorry, ma'am.
Yeah.
Yeah, I think it's now better. Okay, but immediately it disappears.
So there is some connection issue.
Yeah, yeah.
Shaji should give clear-cut instruction. At least they have two sources of connection. If one gets failed, they should be ready with other and the place that you have to take.
So is my screen visible now?
At least not
It's
on
loading.
the screen. Yes, now it has come. It has come. It is there.
Can I?
Network issue.
Yes, Dr. Subi, you are able
Yes,
to.
can I start now?
Okay, you can start it, and I hope that your slide is moving.
Yes, sir. It's moving.
Okay, okay, fine. Then you can start it.
Yes, sir.
I request you in the future presenters also don't put any comment regarding the case. Just you can put that the clinical case presentation. Right?
Okay, sir. Yes.
Okay,
Yes.
no problem.
Good evening, respected teachers and colleagues. I am Dr. Shubhi Singhal, and today I am presenting a case of a 5-year-old girl who presented with progressive facial weakness associated with limb weakness.
Shubhi, can you move this second slide? This is the first slide only.
Yes, sir.
Yeah, now it is right. Yes.
So my case is a 5-year-old female child who is a resident of Kalaria, Indore. She was brought by her mother, who was a reliable informant. She is Patidar by caste and Hindu by religion. The child belongs to a lower socioeconomic background, and she was admitted to our hospital on 8th of April 2026. She presented with complaints of deviation of angle of mouth to the left side associated with drooling of saliva for the past 2 months. She also had progressive weakness of the left upper and lower limbs over the same duration. This was associated with difficulty in walking. I would now like to elaborate the history of present illness in detail. The child was apparently well 2 months back, following which she developed deviation of angle of mouth to the side associated with drooling of saliva. Subsequently, parents noticed weakness of the left upper and lower limbs, which was affecting her daily activities, such as dressing and undressing. The weakness showed a gradual progression over days to weeks, with increasing difficulty in walking, particularly in the form of reduced weight bearing on the left side. There was no history of pain. The illness was also associated with behavioral changes in the form of irritability, anger outburst, along with sleep disturbances such as sleep talking and sleepwalking. There was occasional giddiness, which was more noticeable on waking up without any loss of consciousness. Overall, the illness showed a progressive course without any recovery. I'll now present negative history to further define the extent.
I think, Dr.
and
Shubhi, can you stop sharing? For the negative history, will go for after some time.
Sure, sir. Okay, sir.
Because whatever the information you have provided, let us try to understand. Who are your other colleagues on the screen? Dr. Shubhi, can you identify so that we can interact with them?
Yes, sir. I would like to say.
Madam, I think you can help you, Dr. Anjali.
Yes, sir. So my other residents are Dr. Valerie is there, Dr. Srishti, Dr. Abhinanda, Dr. Deepak, Dr. Bablu.
Okay. So I think
So
it's a
these
good
are
thing.
residents from my
Yeah.
college, yeah.
Okay. So I think if they are
Mariba, yeah.
able to make the video on, if they can, so that we can have the discussion. And please identify yourself. I think so, just S comes. So can you rename yourself? Anyway, who will take the initiation? That whatever the information Dr. Shubhi has provided, how will you try to understand? She said that the here 5 years female girl has appeared. Total duration of the problem is since 2 months. As she described, there is deviation of angle of mouth and drooling of saliva. Simultaneously, she observed the weakness on the left side and some emotional disturbances. If you put all the points together, how will you, I will say, just let us take one by one. What we understand by the deviation of angle of mouth on the left side. Dr. Bablu, can you take it? Dr. Bablu, can you take it? What do you understand by the complaint of deviation of angle of mouth on the left side and drooling of saliva? What problem do you consider? That what is the likely issue with the girl, this girl? Anybody else?
Srishti, Valerie, anybody is there?
Yeah, please.
Sir, it refers,
Okay, Srishti, what do you understand?
sir, deviation of mouth to the left side
I think,
indicates.
Srishti, probably somebody else is there with you and probably both the phones must be on. So echo is there. You can make one phone or one modality off and one, you should operate one particular so that this problem can be avoided.
Sir, angle of deviation suggests us that it possibility of facial nerve palsy that can be in both upper motor and as well as lower motor neuron.
Facial nerve palsy on which side?
Sir, to the opposite side, right side.
Right side. Okay, why right side? Why not the left side? Because there is a deviation of angle of mouth on the left side.
Sir, at the level of lesion, it is usually a element type of lesion, and below the level of lesion,
No,
it is
Srishti, my question is simple. I'm not knowing the upper motor, lower motor. I don't know anything. Just my very simple question. What she's made the complaint that there is a deviation of angle of mouth on the left side. And you say facial nerve palsy on the right side. I will say it is on left side only. Why you said the right side?
Sir, because the muscle involved pulls the angle of mouth towards upward and laterally. That is why in palsy we get the deviation towards the lower side.
Sorry, can you repeat it?
Sir, normally the innervations of the muscles are such that the muscles pulls the lips upwards and laterally. So that is why when there is a palsy, there will be drooping or the deviation of the mouth downwards.
What I mean to say that why you decide that this weakness of the facial nerve is the opposite side of the deviation of angle of mouth. How do you interpret it? That is my question. What I want to make it is very simple. Answer should be in this way, that because angle of mouth left side is deviated, that means it is pulling on the left side. And the reason is that means the right sided muscles are weakness, that these muscles are not able to keep this mouth properly open.
Yes, sir.
That means weakness is on the right side. Am I right?
Yes, sir.
That's why weakness is right side. So right seventh nerve involvement is there. That much you can make the statement. You know, this is very simple, but we should be able to make it. Now, can you make the comment, as we were already discussing, how will you differentiate the facial nerve palsy, suppose if it is there, upper motor and lower motor? That means what other questions you may ask or you may observe from which you can decide that whether the seventh nerve is upper motor palsy or lower motor neuron palsy. Srishti, can you continue?
Sir, we'll ask the patient to do two things. We'll ask about the closing of the eyelids,
Right.
and we'll ask the patient to wrinkle the forehead.
Right.
On that basis, we can differentiate
Can
whether
you
it's
explain? Can you explain what will you observe?
Sir, if the forehead movement is absent, then it will suggest an element type of palsy. That
Right.
is that the whole side of the face will be affected. So the child will not be able to close the eyes and there will be deviation of the mouth. But
Right.
if the forehead is spared, there is only lower facial weakness. That is, if the forehead plus eye closure is normal, then it will suggest an UMN type.
Suppose if you are expecting, or so there is a seventh nerve right side upper motor neuron of lesion. Here it is the right side, right?
Yes.
And if it is suppose upper motor neuron type, what you will get on the forehead and what you will get on the eyes?
The forehead and eyes will be normal in UMN lesion. There will only be deviation of mouth to the left side and a right-sided upper motor neuron, right-sided upper motor neuron palsy of the seventh nerve.
I think very simple. That is the upper motor neuron type of lesion. Because there is a bilateral innervation.
Yes, sir.
This upper forehead movement and wrinkling and the eye closing will not be affected.
Yes, sir.
While in a case of lower motor neuron type of lesion, what happens, Srishti?
So there is bilateral innervation is not there. There is only unilateral innervation.
So what happens?
So therefore, both the forehead as well as the closing of the eyelid is affected in element type of lesion.
You can say that half of the face on the same side is affected.
Yes, sir.
Right. Very simple to understand. That half of the face on the same side is affected, not on the opposite side. Very good. So here, in short, Srishti is making the, I will say, interpretation that in this girl, right side facial nerve is involved. I think Shubhi has not made the other points clear. Later on we can, or even on examination will confirm. Now the second complaint, what Shubhi has described, that is the left upper limb, lower limb weakness and gradually progressing. What do you mean by that? That means vary the site of lesion. You know, I think many times we are discussing in every case that always try to think that vary the anatomy. Which part of the nervous system is affected? Try to think. Then second thought you may give that what type of pathology is likely. And third, you can put the possible etiology. Very simple. And if you are, I would say, try to answer these questions, probably your thoughts will be clear. So the second question, left side weakness, gradually developing, upper limb, lower limb. What does it indicate? Who will take it? Srishti, who is your other colleague? Please, can you help me?
Sir,
Or madam can help. Yes,
Dr.
Srishti.
Deepak, Dr. Valerie.
Dr. Deepak and Dr. Valerie can answer.
Okay, Dr. Deepak or Valerie, any of you can take it, please. Come on.
Hello.
Yes.
Good
Very
evening,
nice.
sir.
Deepak, I will appreciate you that you are taking your own. Please, come on.
Sir, as from the history, it is evident that on the right side of the facial nerve is involved, and the patient is also having left-sided weakness of the body involving upper and lower limb.
Very good.
So the lesion might be in the brainstem, sir, because in brainstem lesion, we get crossed hemiplegia. We used to get ipsilateral facial nerve, ipsilateral cranial nerve lesion, and contralateral weakness, contralateral hemiparesis, sir.
Very good. Deepak, my question to you, suppose the midbrain is affected, brainstem is affected. Which cranial nerves are commonly affected?
Sir, in the midbrain, sir.
Because you know here what she made the, I will say, clarification that only seventh nerve is affected.
Yes, sir.
Whether the seventh nerve comes over this area? Or which other cranial nerves comes over there? You know, midbrain, that is the brainstem, pons, medulla. These are the different divisions. And suppose if this part of the brain is affected, then which cranial nerves are commonly, you will see, evidently affected?
Sir, in the midbrain, usually we have a cranial nerve 3 and 4 nucleus in the midbrain.
Yeah, very good. 4, 6 may be there. Then,
yes,
suppose
sir.
still if you go further.
Yes, sir. And if we get any lesion in the midbrain, sir, so then we get features of cranial nerve 3, 4, and 6 palsy. We could get ptosis, diplopia.
Anyway, suppose still the lesion is below even this part, 3, 4, 6. Then which other cranial nerves will be involved?
Sir, below this lesion,
you know, if you remember the anatomy, then midbrain is commonly, I would say, having the anatomy of most of the cranial nerves. Upper one, third, fourth, or sixth may be there. Later on, even you may get 8th or 9th. And still, if you go below, even vagus and 12th, 11th or 12th will be involved. So this type of the sequence will be seen. Here, somehow, what Shubhi has described, there is no point of involvement of all these cranial nerves. Very rightly you say that the evidently right side facial nerve and the left side hemiparesis or the weakness. Right. Then what will be the common site, anatomy?
Sir, it might be pons, sir. because
Okay. You know, Deepak, if I remind you the anatomy, the first part is the cortex as a whole.
yes, sir.
In the cortex, if the lesion is there, very mild or very limited motor involvement is found. And with the cortical involvement, seizures, speech problem, memory, cognition, all these things will be affected. In our patient, Shubhi has not mentioned any of this complaint. So we understand that probably cortex is not involved. Second part is the subcortical or corona radiata, what we say. If you remember your anatomy, that fan-like fibers are going below the cortex, fan-like fibers. There is corona radiata. Corona radiata motor deficit will be almost same like the cortex, but higher functions will be spared. Below that, which is the area where the compact pyramidal tract fibers are located, Deepak?
Sir, it would be internal capsule. Sir.
Very good. Yeah, you know, but the only thing my job is to bring from you. It is an internal capsule. An internal capsule, if you remember, there is the anterior horn, genu, and posterior horn. Now,
Yes.
where is the part of the facial nerve comes? If you remember with the reference to internal capsule, there is some part of the facial nerve. Anyway, but that is very certain that internal capsule and facial nerve is having some association. And having this type of the anatomy, probably internal capsule area is likely involved. But still, she says that later on the irritability, younger outbursts, sleep disturbances. So these problems are there due to what? Which part of the nervous system is likely affected? Which manifest in the form of the irritability, younger outbursts, sleep disturbances. Can you make some comment?
Sir, the patient is having some behavioral changes.
Yeah.
So some subcortical structure might be involved, sir.
Right. Can you name some of them? Subcortical which structures?
Sir, subcortical structures involves the basal ganglia, sir, and
Okay.
thalamus.
Okay, but you know, basal ganglia will be different. That will be more of the movement disorders.
Yes, sir.
Right. That will be the form of the either the dystonia or choreoathetosis. These types of disturbances are more common. Anyway, but you know, that means again these are some cortical functions, and therefore diffuse cortical and more. If you say more of the, I would say, emotional problems, then frontal lobe is possible. That frontal lobe is having these functions. So I think from these complaints, we understand anatomy point of view that this 5-year-old girl has problem of 2 months, which particularly likely the internal capsule involvement, right side, because the facial nerve is involved, and the left side, the weakness. Possible that there is some diffuse lesion of the frontal lobe, which we can explain with the manifestation of particularly the emotional disturbances. That is very simple. Anyway, I think this is anatomy. Anybody can now take that. What type of the pathology is possible? Dr. Anjali can, madam, you can help. Yeah.
Dr. Harishma or Garima can help.
Yes, Garima, come on. I think, you know, Deepak and all these people, they answered very nicely. I understand that being the resident, it's difficult to answer, but still they responded very, very rightly. Where is Dr. Garima?
Good evening, sir.
Yeah, Dr. Garima, now you can take the pathology part. That can you make some comment that what type of the pathology, what structure is likely involved, which can manifest in this fashion?
So there is the history suggests a gradual progressive weakness which
Right.
might point towards any space occupying lesion.
Okay.
Since there is no history of
Garima,
fever infection.
Garima, sorry to interrupt you.
Pardon, sir?
Sorry to interrupt you, but suppose any space occupying lesion, commonly how they manifest? What are the symptoms
So
commonly?
usually space occupying lesion, sir, according to Monroe Kelly doctrine, if there is a space occupying lesion, they usually present with features of an raised intracranial pressure.
Fantastic. Yes, Garima. So what will be the signs of raised intracranial pressure? Very
So,
good.
the patient will present with bradycardia,
I think that will be later on. But what will be the symptom that you may get on examination?
So symptoms will lateral rectus palsy, sixth nerve involvement will be there.
Before that, that may be the false look.
Headache,
What will be the
headache,
symptom?
vomiting.
Very good. So come
Blurring
on,
of
headache.
vision.
Let me go
Yes,
one by one. Try gradually we'll understand. Headache and vomiting. These are the very classical signs of raised intracranial pressure. Agree?
Yes, sir.
Can you make some more comment at what type of headache and vomiting? Any classically diurnal problem or something? In a raised intracranial pressure?
So patients present with projectile vomiting.
Very good. Yes. Any specific time in the day initially? Any idea? Yeah, Garima, I will help you. You know, classically, please remember all the students, that is the raised intracranial pressure, if it is slowly progressing, then commonly it starts with the early morning or morning headache and vomiting. Particularly the headache. After the vomiting, the child is getting the relief from the headache. It will be, I will say, at the beginning of the disease. Once gradually progressive and it sets in the disease, raised intracranial pressure, then it may be the continuous and persistent vomiting. But at the beginning, initial stage, if you ask, and probably sometimes that's why, you know, mother is taking, because she has to go to school in the morning, she vomits out. She is complaining headache. And sir, after this vomiting, she is fine and playing. That may be her parents' interpretation. But with the progression of the disease, she will say that now, sir, it is not so in the morning. Otherwise, also the vomiting is there. Just listen to the story. That with very classical raised intracranial pressure. That can be in a case of hydrocephalus. That can be in a case of space occupying lesion. Suppose with a fever or something, then it can be with the bacterial meningitis, maybe the encephalitis. You know, so many things. So I think that's the point that somehow, Garima, in this patient, should we have not complained of headache, vomiting? Therefore, probably we are not thinking for the space occupying lesion or raised intracranial pressure. Then what else you will think? Very good. I will give you some idea, Garima. I know that you must have read, but I should remind you. You know, commonly how we think. Is it congenital? Is it traumatic? Is it infective? And infective also, is it bacterial, viral, tuberculous, fungal? Or if it is really due to space occupying lesion? Or it is really some neurodegenerative disorder? Or it is vascular? In vascular also thrombosis, hemorrhage or thromboembolic phenomena. You know, these are the very, it is autoimmune disorders. And every group is having the very characteristic of symptoms. Now, having the symptoms of hemiparesis and the facial nerve involvement, out of all these various pathological syndromes, which one you will consider, Garima? I have given lots of information to you.
Yes, sir. So there is no history of fever, so infective etiology can be ruled out.
Very good. Please, Garima, in the medicine, never rule out. Possibility less. You know, sometimes tuberculosis with mild fever, without fever also can come. So totally we cannot rule it out, but I agree with you that the infection goes down. Okay.
Yeah.
Nice.
So there is a usually in trauma, there is an acute presentation.
Very
so
good.
Trauma is less likely.
Very good. You know, suppose there is a road accident and already there is a history of fall or some head injury and the child is brought to you. Naturally, first you will consider the trauma. Or suppose history of fall from some height. Then in that situation, with this type of history, but there is no such point. Therefore, trauma is less likely. Congenital, I will say it start early age group. Up to 5 years, there was no problem, so less likely. So congenital is less likely, traumatic is less likely, infected is less likely. Garima, fantastic you are discussing. Raised intracranial pressure conditions we are not considering. Then what else you will consider?
There can be any degenerative etiology.
Okay. Garima, what is the characteristic of degenerative disorder? What is the characteristic? One line only.
So there, in a degenerative etiology, there's we can see neuroregression.
But yeah, so what will be the complaint?
So there will be regression of milestones.
Yeah, exactly. That child was able to walk, child is able to run, or even so gradually that part is lost. That now not able to walk, or not able to even write, or not able to, that means there is a loss of the milestones which already child achieved. I think here it's that type of complaint is not there.
Yes, sir.
So degenerative is less likely. Then what else? Second, now if I remind you gradually, Garima, I will give you the idea.
Yes.
Already we discussed that probably the site of lesion is the internal capsule, where
Yes,
compact fibers, if you remember the anatomy, there are pyramidal tract dense fibers are there.
Yes,
and therefore even small lesion can cause more damage, half of the body.
Yes, sir.
And then what is the most common, I would say, pathology here?
So, infarct, stroke.
Yeah, so it is due to what? Due to what? Due to what?
Leading.
What structure is involved? Structure.
Any stroke and around the internal capsule can lead to dense hemiplegia.
Yeah, but Garima, what is my question? Which structure is involved? Vessel.
Yes.
Right? It is vessel problem.
Pardon, sir?
It is a vascular problem.
Pardon, sir, what?
You know this pathology, that means which structure is involved? Some vessel is involved. Blood vessel, blood vessel supplying this area. And if the blood supply is cut off or compromised, it will cause ischemia. It will cause infarct. Am I right?
Yes.
And therefore we can think the vascular problem. Now the vascular problem, which vessel is located over here anatomically? Which vessel is supplying to the internal capsule? And if that vessel is affected, it can cause the hemiparesis?
Middle cerebral artery.
Very good, very good. Yeah, so you are knowing all the things. Most commonly, it is middle cerebral artery. Of course, if you go in the details, there may be the different branches, but I think with the clinical presentation, we can consider involvement of middle cerebral. Now the middle cerebral, Garima, again, due to what? Because there can be the embolism, there can be the thrombosis, there can be the thrombosis embolism, or there can be the hemorrhage. Out of all these, which one you are suspecting in our patient?
Ischemic is most likely. There is no history of any raised IC, complaint of features of raised ICP. So hemorrhage is less likely.
Okay.
So we are considering ischemic.
Very good.
And there is gradual progression.
Fantastic. So gradual progression, what does it indicate? Anyway, now I will help you. Please remember all the students also. Whenever you are thinking for the vascular problem, think that in what way likely the vessel is affected. Is it due to some embolism? Is it really due to some thrombosis? Sometimes together thromboembolic phenomena or hemorrhage. Now, this insult is having the very characteristic manifestations. Embolism, that means source of embolus is somewhere else. It got detached and lost in the middle cerebral artery. And then it will be the very acute, suddenly. Suppose, and classically, what are the sites of the embolus? Commonly heart. In a case of cyanotic heart disease, back to endocarditis, there is a vegetation. It gets detached, goes in the circulation, and loss in the middle cerebral artery, and then this manifestation classically develop. Therefore, commonly you will ask the history of congenital heart disease, particularly cyanotic heart disease, like phallostetralogy, or even bacterial endocarditis. They can present it this way, embolus. That is number one. And embolus will loss of middle cerebral, suddenly child presents with weakness on the opposite side with even the facial no enrollment. Thrombosis, that means gradually there is a blockage of the vessel. And that will take some few days to weeks together. And that is more likely the thrombosis. Hemorrhage will be very sudden and catastrophic. That means many times you listen in the adults it is very common, old age person, that he was sitting reading the newspaper, suddenly fell down with unconscious convulsions, brought to the hospital and detected hemorrhage. That is very catastrophic, like manifestations are in hemorrhage. And therefore, what we call it is hyperacute, not even the acute. Acute, that means few days, 7 days, 10 days time. Subacute, few weeks. Chronic, weeks to months together. And hyperacute, that means previous moment person is normal and suddenly, and whenever hyperacute, either it is vascular or some immunological like anaphylaxis. So that we can understand. Now coming back to our patient, Garima, again I will be back to you. In our patient, what Shubhi had described, that the weakness was gradual, progressive, slowly. So what does it indicate? Vascular, what type of the problem? Garima, after this discussion?
Yes, sir.
After this discussion, what we are thinking, whether embolism, hemorrhage or thrombosis?
So the most likely, sir, there is thrombosis of the in the region of middle cerebral artery is more likely because there is no history of there is no sudden event.
Sudden insulting, the sudden manifestation
sudden insult is less likely.
Yeah.
Sudden history is not there, and there's
very good. So I think you know how much you are able to think, and therefore now the second thing you will have to go for possible etiology. Please, what I want to give the ideas to all the students in any CNS case with the presentation. First, try to define the anatomy. Which part of the nervous system is affected? Is it central or periphery? Like that. In central, is it cortex, subcortical, internal capsule, midbrain, pons, medulla? Or later on periphery, their anterior horn, peripheral nerve, neuromuscular junction, or muscles. Very simple. And every component is having the very characteristic. Here, after this discussion, we decide that likely it is an internal capsule lesion. Pathology is likely involvement of middle cerebral artery, and possibility of pathologies may be some thrombus phenomena. That is more likely. Now, what common causes you can keep in mind for this type of the thing? Let me go to somebody else. I will say all these students did the really fantastic job. Deepak discussed very nicely. Garima, Srishti, at least I remember, and I will not forget them. Even Dr. Bablu. Bablu tried, but I think could not due to some.
Harishma is also there, and Neeraj is also there.
Yeah, Dr. Neeraj, can you take it?
Harishma, Neeraj, are you there?
Anybody?
Yes, ma'am.
Yes, please come on, Harishma.
Yes.
Good evening, sir.
Good evening. Harishma, can you give the thought? Already, I hope that you were there, you listen our discussion.
Yes, sir. Yes, sir.
Yeah. So probably these possible anatomy pathology. Now, which type of the insult or problems, what we are thinking, either the some thrombosis or embolic phenomena is likely. Can you give some common conditions which can present in this way?
Sir, if you are thinking of embolism, as you are discussed, it can be of cyanotic heart disease.
Yeah, so it is not there.
Yes, sir.
Right?
So we can think of arteriopathies.
Right,
Sir,
very good, very good. Can you
like
give some example of arteriopathy? Very good.
like sickle cell arteriopathy, Moyamoya
Okay.
disease.
Yeah,
Um,
fantastic, fantastic. So all of you are knowing why you are not discussing. Arishma, why you are silent for so much time? Very good. You know, various vasculopathy. Can you give some, even the causes for the vasculitis or vasculopathy? Some conditions which they can present with the vasculitis or vasculopathy. One is you are given the sickle or moyamoya. Anything else?
sir. SLE or Takayasu arteritis.
Okay, you know, Takayasu will be present different, but the vessel involvement is possible. Agree with you. But here with that, this type of presentation, any infection, can you consider? All the fever is not there, but sometimes mild fever, without fever, even it can present. Which type of infection? Which is common in our country?
So TB.
Tuberculosis can present even. We don't know the detail, but even this, suppose some weight loss, some contact or something in the past year given EKT, we are not knowing all the points, but at least we can keep in mind that maybe even tuberculosis is possible, sickle is possible, or even post-chickenpox vasculitis. We don't know the history of chickenpox, but that can also cause. Mumps can cause. Even any viral infection can cause. Sickle can cause, as you mentioned. Any metabolic disorder, you have any idea? Any metabolic disorder?
Like homocystinuria, mitochondrial
Very good.
diseases.
Yeah, homocystinuria is known to present in this way. Recurrent even thromboembolic phenomena. So on the contrary, I will Dr. Anjali, I will say that all your students are really fantastic. Somehow they are, I will say, very shy. That's why not speaking, but they know everything. So anyway, I think these are the various possibilities which we'll keep in mind. And then we'll try to gather the information in the history. Whether is there any point is there suggesting tuberculosis, even the sickle cell, or any metabolic disorder, any viral insult, anything can be there. But these are the points. I think now you can understand that only from the first or second slide, how much we understood from the history only. Of course, now the rest of the points in the history we will check how much it is helping us, and then probably we will try to decide that what will be the findings on examination. But fantastic, I will say very good case. Even the selected Shubhi has given the good information, and even all the students discuss very nicely, very nicely. Shubhi, now you can take it. I think before we go further, any teacher suppose wants to say something, some point is missed, or there are some different ideas or thoughts. Please, anybody, any teacher.
Thank you, sir. I think the whole idea of this presentation is that everybody should interact, and the common mistakes that postgraduate do in the exam, they should be avoided. So I think the today's discussion is not only fruitful for the participants, but also those who are hearing and those who are interacting, they will be benefited even far more. So I think more and more PGs should interact on this forum without hesitation. And sir has beautifully clarified all the concepts of presentation of a case of hemiparesis, and we are very thankful to sir for the same.
Yeah, I think Dr. Anjali encouraged the student that I appreciate, and all the teachers should do. And certainly, I think they are answering fantastic. Anyway, Shubhi, now you can share your PPT and take the history further. I think I will request Dr. Anjali. Madam, you please remember the one point which Dr. Neelam Mohan has requested us to inform to the students. So I think after some time, please, you can do after the history completed. We should not forget it.
Yes, sir.
Yeah. Okay, Shubhi, you can take it further.
Shall I repeat the HUPI?
Yeah, no, I think now you can go to the point where we
negative history.
Stop. Yeah, negative history, yes.
Yes, sir.
Please.
So first, sir, under negative history, first, there is no history of seizures or involuntary movements. This was asked to rule out any cortical involvement or encephalitis. And there is no history suggestive of involvement of any other cranial nerve. For example, there was no history of blurring of vision or hearing loss or dysphagia, dysphonia, or any nasal regurgitation. There was also no paucity of
I
movements
think
of
because you are explaining simultaneously, suppose blurring of vision, which cranial nerve is likely involved?
So, for blurring of vision, so we can say the second cranial nerve is likely involved
Okay.
if there is blurring
There's
of
the
vision.
optic
Yes,
nerve.
sir. Optic nerve, yes, sir.
Okay. And suppose the third, fourth, sixth is involved, what will be the complaint?
So third, fourth, sixth, we will have difficulty with vision, like there will be doubling of vision or
Very good, very good. Yes. That means double vision, likely the ophthalmoplegia.
ophthalmoplegia.
Blurring of vision, likely this perception, and therefore the optic nerve. Very good. Hearing loss.
So hearing loss for eighth nerve or
Right.
gross.
And dysphagia, dysphonia, nasal
And nasal
regurgitation.
regurgitation. These were asked to check for the 9th and 10th in cranial nerve involvement.
Okay. Dysphonia is due to what?
So speech abnormality.
Yeah. Which nerve particularly is involved? Recurrent laryngeal nerve. And it is supplied by vagus nerve. Right.
Vagus.
So that you can say. So dysphagia, dysphonia, regurgitation, that means 9th, 10th.
9th, 10th.
Even
yes,
there will be the nasal twang in the speech also. Right. Okay. Then
next, there was no paucity of movement on the right side, no sensory disturbances such as numbness, tingling, or abnormal sensations.
Right.
And there was no involvement of bladder or bowel, no persistent headache, early morning vomiting, or altered sensorium.
Very good. You have mentioned this. That means no signs of raised internal pressure. Good.
Yes,
Next.
sir. There was also no history of prolonged fever, weight loss, bone pain, night sweats, or any other chronic systemic symptoms. No history
Should we I think better for the, I would say, clarification. You can explain the reason for all these. Suppose fever, weight loss, bone pain.
Yes, sir. So, the history of fever, or weight loss, night sweats, or any other chronic systemic symptoms was taken as there is no such history. So, this reduces the likelihood of any chronic infective or systemic malignant etiology.
Right. Okay.
Like it can rule out. We can say that the tuberculosis or any
Yes.
condition like rheumatic fever or leukemia, they become less likely.
Right.
Next, I asked for about pallor, jaundice, and pain crisis. This was asked to screen for hemolytinemia or any sickle cell disease with the cerebrovascular event.
Very good.
And their absence supports that there was no such history. And next, no history of cyanosis, cyanotic spell, or cardiac surgery. This I asked is to look for any cardioembolic stroke sources like congenital heart disease or any embolic stroke in the past.
Right.
And no history of rash, joint pain, or sore throat. This was I asked to look for autoimmune conditions or any viral exanthemas or any sore throat leading to maybe an indication of rheumatic fever.
Very good.
And no history of diarrhea, vomiting, or dehydration followed by seizures or coma. This I asked to rule out, or by asking this, metabolic cause or events like sagittal venous thrombosis due to dehydration, they becomes less likely.
Very good. Very good. Yes. Nowadays, fortunately, these problems are less seen in the practice, but we used to get several patients. They're following this diarrhea and vomiting. There is a dehydration, even the polycythemia or hemoconcentration, predisposing to the thrombotic phenomena, and the patient may present with even these hemiparesis. So nowadays, fortunately, we don't get much common, but yes, it is possible. Good. Recurrent attacks of hemiparesis?
Yes, sir. This was asked to screen for any episodic neurological disorders in the past, like any events like transient ischemic attacks. Or
can you enumerate any condition which can present with recurrent attacks of hemiparesis? That means develop the hemiparesis, recovers, again the hemiparesis develops, like that you may get the several episodes.
So
do you have any idea, any condition?
So although our patient has no history of seizures, but in case of epilepsy,
Dr. Arpita had mentioned sickle. Okay, Arpita, you are right. Sickle can present. Anything else?
TIS, transient
Harshima?
ischemic attack.
Sorry?
Transient ischemic attacks.
Okay, transient ischemic. Anything else? Hypokalemic periodic paralysis will be different presentation, will not be the hemiparesis. It will not be only one side, it will be generalized. But here it is the only hemiparesis and recurrent. Dr. Shivani has put multiple sclerosis. Again, Shivani, multiple sclerosis will be the different neurological manifestation, but okay. Very specific, which are known to present with the recurrent attacks of hemiparesis. Sickles, I think somebody mentioned, that is right, Arpita probably mentioned. Another thing, even the migraine. Migraine is known to present with even the alternate hemiplegia or recurrent hemiplegia or hemiparesis. Similarly, already I think who answered, but homocystinuria. Homocystinuria is known to present with the recurrent thromboembolic phenomena. Even moya can present in this way, recurrent. So I think so many conditions. Another thing I will convey to the student that once you mention in the exam, please be prepared that such of the questions are going to be there. And there you should be able to answer. Okay. Otorrhea, what is Shubhi, what is your idea of otorrhea? What otorrhea can cause?
sir, it can lead to secondary brain abscess. So
Yes, right. Even cause
that-
meningitis.
Yes, it even can
Yeah,
cause meningitis.
right.
And the history of trauma or any toxin exposure or drug exposure and recent
Yeah, but I will again I will convey. Okay, you can put it, but commonly, any toxin or drug, they will present with a very acute condition. Very acute condition. And suppose acute condition, that means patient child was fine on the previous day, evening or night, and suddenly the morning found with the problem, or even after a few hours, even the daytime. That means it is some toxin, snake bite, or some drug. But it will be usually acute or hyperacute. Okay. And which vaccine should we can present in this way?
Sir, MR vaccine or rabies vaccine can present with any in such condition where they can because they can cause demyelination.
Commonly they will present with this, I will say encephalitis like picture. That is more common.
Yes.
Okay. Or GBS like picture.
Yes, sir.
Fantastic. But again, I will draw the attention to all the students. Please mention the negative points, not very long list, which is given in the standard textbook. Out of all these points, select relevant to your case. Right? Whatever the relevant to your, I will say, presentation of the patient. Okay, but good points are covered. Shubhi?
Yes, sir.
Go ahead with this history part.
So next is the past history. There is no history of similar illness in the past and no prior hospitalizations, surgeries, or any blood transfusions. The child was born full term by normal vaginal delivery with a birth weight of 3 kilograms and had no antenatal or perinatal complications. There was also no history of any NICU admission. Developmentally, the child was appropriate for age with all the milestones achieved on time and good scholastic performance prior to the current illness.
Right.
There is no family history of any similar illness or tuberculosis or neurological disorders or any sudden death.
Yeah. I think here specifically always tuberculosis context should be stressed. Yes, we have done it. Good. Go to the next point.
Coming to the nutrition history, the child is on a home-based vegetarian diet with as we can see from the table that she's on a suboptimal calorie and protein intake for her age. She is immunized as per the national immunization schedule, although she has missed the 5-year booster dose. The child belongs to a lower socioeconomic background and socioeconomic status was assessed using modified Kupusomi scale.
Okay.
So coming to the clinical interpretation of history, we have acute progressive focal neurological illness which involves the left side of the body, that is left hemiparesis. Second is crossed motor findings of right side facial weakness with contralateral limb weakness, which suggest a brainstem lesion due to the crossed motor findings. There is likely involvement of the facial nerve pathway and corticospinal tract, which clinically favors towards a pontine lesion.
Okay. Can you stop sharing? I think history part you have completed. Shubhi, can you stop it?
Sure. Sir.
Right. Very good. I will again back to the students, please. All should be ready. For this summary, she has, I will say, elaborated the history in details. Now from that, already she has given her summary. Summary should be of, I will say, very short, that what is your interpretation from this information? And then try to answer, think in this way, that which part of the nervous system is affected, that is anatomy, what type of pathology it is, and what is the likely etiology, possible etiology, because etiology we may not be able to decide from just history, unless there is some obvious one. But you can think the different etiology. So having this type of the history, who will, two people should be ready to give the summary voluntarily. I should not mention. I note the presence of Dr. Sagrika after a long time. Now she is consultant pediatrician, but in the past I remember Sagrika is a very good student and presenting the cases multiple times. So I'm sure that will be a good inspiration to all other students. So now, Harishma, can you take it? Harishma, I think, am I right at the way in which I am pronouncing your name, Harishma?
Yes, sir.
Yeah. So now you can give your, I will say, summary, your own way.
There is.
Harishma, I'm sorry, before you start to speak, I would like to ask you the one question. Harishma, are you watching television?
No, sir.
Not at all. Array. I'm not sure what should I say, good point or not good. Why I'm asking purposefully. If you watch at any time, particularly Indian Idol, that Saturday, Sunday, probably that television show is there. In that, if you see, we can get the inspiration or ideas from this type of the, I would say, shows also. It is for the singers.
Okay.
And every, I will say, singer, participants, they I will say, sing in their own ways. Sometimes they are innovative. That what even the past senior singers have sung the particular song, but they will modify and they will go in their own way. And sometimes there, I will say, judges, they are appreciating that yes, you have innovated it, you have done in your own way, and it is really better than even the original song. So Harishma, that is the thing which I wish from you, that this summary should be in your own way. It should not be, I will say, standard or what the people do. So how you will, I will say, present the summary of this patient? How will you do?
Sir, the patient is having a subacute onset of gradually progressive right.
Harishma, sorry to interrupt you, but for the sake of students, I will say she has started in a really, I will say, beginning is good. Always use the multiple adjectives in the summary. Is it acute, subacute, chronic? Is it really that lesion, whatever the pathology, is really static or progressing? Suppose if it is progressive, if it is slowly progressive, it is rapidly progressive, and in that way it becomes, I will say, good idea. Harishma, you can take it further. Sorry.
Sir, according to functional classification, it's a subacute onset, left-sided left-sided hemiparesis with
Right.
Right-sided element facial palsy.
Right.
With no focal motor deficits or cranial, with involvement of seventh cranial nerve and
Okay, fine.
sir, anatomically, if we try to localize the lesion, it is most likely of right MCA, in fact, probably thrombotic etiology in subcortical region, most likely either internal capsule नहीं तो pons brainstem में हो सकते हैं, mostly because there is contralateral hemiplegia and ipsilateral facial palsy. It could be of pontine lesion. So
Harishma, now I have the two questions for you.
yes,
What are the symptoms or the points from which you are suspecting pontine problem? Or classically, you must be knowing any pontine lesion, what will be the presentation of the patient?
so mostly patient present with contralateral hemiparesis and ipsilateral element facial palsy.
Okay. Beside that, what will be the general condition of the patient or pontine lesion?
Patient will be.
You know, why I'm coming to the point, usually to pontine lesion are the serious lesions. They are catastrophic like.
Yes,
Usually patient will not be in the good shape. That is the most common presentation. You know, associated some mild lesion is a different story. That you may get, I will say, in some neuroimaging. But clinically, what I'm watching, that at present, no point suggesting the pontine lesion in the history.
Yes.
Because, you know, pontine, still we are not examined. Probably Shubhi may give the point in the examination. Suppose what you are expecting on examination, let me ask you in this way. Suppose pontine lesion. What you are expecting on examination? Which will suggest, yes, it is a pontine lesion?
So in cranial nerve examination, there will be element type of facial palsy. That is both forehead, eyes, and same side of face is involved. And angle of mouth will be deviated to the opposite side.
Okay, anything else beside that? Besides
So pinpoint pupils.
Exactly. You know, pontine any condition, most commonly the hemorrhage one. That's why I said it is a catastrophe. Yes. It's a patient will not be in good shape, good condition. General condition will not be the good. Even beside other things. So even suppose neuroimaging is showing, probably I'm not sure how we are biased, but to me, clinically at present, there is no point indicating the pontine. I will not even consider from the clinical presentation. Second, you know, pons again, if you remember, what are these particularly the vital centers in the pons?
So respiratory centers.
Yes, absolutely, you are right. And then how the patient presents with the pons involvement? You know, respiratory
patient chain stop breathing.
Yeah, again, patient will not be in good shape. Am I right? General condition will not be the good of pons involvement. Whatever may be the pathology, whether it is the herniation, whether it is really some Guillain-Barré syndrome, what we used to say whether poliomyelitis, bulbar or something, whatever the condition, etiology, but with the involvement of pons, with the involvement of the pontine, the general condition of the history, the way in which Shubhi has described, does not favor us. Right. And therefore, but I will say you have put your way of history and summary very nicely. One more person, who will do? Either the Deepak or even the
Shivani and Dr. Shivani or Sneha.
Shivani has not participated probably. She can. Yes.
Yeah. Shivani, are you there?
Even
Sneha or Shivani, anybody?
Even Srishti was there. Srishti, can you take it? If Shivani is not there?
Yes, sir.
Yeah, please, come on.
So according to the history, it suggests a subacute progressive weakness
Right,
with, as Harishma mentioned, element type of facial nerve palsy. Plus,
right.
there are some more positive factors in the history, such as the child has behavioral and mood
Yes, very
changes
good.
that help us to localize the lesion more to cortical level of
Yeah,
lesion.
very good.
Apart from that, sir, since we can also further narrow it down, it would be an acquired condition.
Right, very good. One
And
more point she added. Absolutely, it is not congenital, it is acquired. Very good.
yes, sir. And apart from that, if we after the localization of the lesion, if we move to the etiopathogenesis,
Right, yes.
then we have it as very slowly progressive. And as we discussed, the lesion, the presentation is not such catastrophic. So it could be a space occupying lesion, or
Okay,
it could be vascular etiology favoring thrombosis.
fine. Fantastic, fantastic. Anyway, I think just I will, suppose somebody asks me how I will put it. Very simply, I think summary should be presented. We can say here 5 years old female has presented with 2 months duration of the illness. It is subacute in nature. All the students mentioned very nicely. It is insidious of onset. It is not the catastrophic, sudden, and slowly even the progressive. From the already discussion from the anatomy point of view, it is the central nervous system involved. So peripheral nervous system is out. In the central nervous system, again, probably is very specifically with the left side hemiparesis and right facial palsy. My clinical consideration of anatomy, the internal capsule. Of course, with some emotional outbursts, probably maybe the involvement of diffuse frontal lobe involvement. Having this, I consider that the vascular type of the pathology, maybe in the form of some vasculopathy, vasculitis, or some thrombotic phenomena. Etiology point of view, very difficult to say, but various reasons for the vasculopathy I may consider. Very simply, I will say you can put it, and from the history, I will say I'm sure that most of the examiners will appreciate it. Now, before Shubhi goes for the examination, I would like to know that what you are expecting on examination. I think as a good clinician, please decide your mind that having this type of presentation and my understanding, interpretation, if you examine the patient, what you are going to get it, or particularly which point you will examine, so you will not miss it. Who will do this exercise? Any
Sir,
person?
can I ask a question?
Yes, has to be. Please, you should ask the question.
Since
Please,
there's
come
a case of contralateral hemiplegia, so
Right.
can we localize it above the level of brainstem? Because if the lesion is above the level of brainstem, or
Yeah,
it
I think your point is valid, Subhi. I understand, and probably difficult to answer clearly. But what I will suggest, still we are not sure whether the facial nerve palsy is upper motor or lower motor. Number one.
right, so
If it is upper motor, it favors particularly the facial internal capsule. If it is really of lower motor, naturally your points that it should go below the internal capsule and then midbrain. Any part midbrain, brainstem, that is the midbrain, pons medulla. Pons medulla less likely, than probably brainstem we can consider. I agree with you. And various syndromes are there. I think Goubard and some, I don't remember even Benedict syndrome, various syndromes are there, where classically contralateral hemiparesis or hemiplegia and that particular side of the facial palsy will be the presentation. I think it will be more clear on the examination. Let us see what are our clinical findings, and then again we'll be back to correcting that what is the likely site of lesion. Right? Agree. But as I said, we wanted exercise that what you are expecting on the examination or what you will check even, that you should not miss all the points which we discussed, various possibilities. Who will do? I think one person should give me the expected findings. Either the Dr. Sneh, Srishti, I think Dr. Shivani, as Dr. Anjali mentioned. Dr. Shivani, are you there? Or some
Deepak or
others?
Deepak can answer if he's there.
Yes,
Or
Deepak. I think
Ariba.
Deepak was the person to start this,
Even
I would say.
Abhinanda, are you there? Abhinanda? No.
Anyway, I think Deepak is ready. Deepak, come on.
Good evening, sir.
Yes, good evening. What points you will examine and what you are expecting that this finding should be there?
Sir, as from the history, it is evident that it might be right-sided lower motor neuron facial
Deepak,
with left-sided hemiparesis.
Deepak, you will not jump for the CNS. Always give the general impression. Suppose general examination, whether patient be conscious or unconscious. Start like that.
So the patient would be conscious.
Okay, that's the point. That you are expecting that the patient may be in the good situation, good condition, probably conscious, maybe probably some altered sensorium or something, but not that bad, right? That is your expectation. Okay, on examination maybe something different. It's a different story. What else? General vitals, Deepak? I will guide you actually what
Sir,
you should check in
vitally,
vitals.
Yes, sir. Sir, in the vitals, we would first take the sir heart rate. There would be
Yeah,
no
but Deepak,
tachycardia or bradycardia.
Deepak, what you are expecting in this patient? Whether you expect some bradycardia, tachycardia, some respiratory problem, something, do you expect that in this patient this is likely? Probably Deepak's connection is lost.
Bradycardia is present in based ICT, sir.
Okay, Harish, in this patient, that already we discussed in a raising a pressure, okay, but in this patient, do you expect this bradycardia?
No, sir.
Yeah, so that what you are expecting, that is a very clear question.
Sir, hypertension can be present in vasculitis.
Very good, very good. So check the blood pressure. Very good.
Yes, sir.
Even we should not miss it. Anyone, I would like to check the blood pressure in all the 4 limbs. I will verify that yes, hypertension is not there and in all the 4 limbs normal or really some difference. That we should check it. Very good point. Okay, what next you will keep in mind?
Sir, we should check for carotid bruit for arteritis.
Yes. Check the peripheral pulsations. We should check all the peripheral pulsations. Even carotid. Absolutely. Sometimes you know that carotid problem can give rise to all these issues. So carotid and other peripheral pulsations, particularly popliteal, dorsalis pallis. Very good. So that pulsation should be checked. What next, Harishma? Very good. What next?
Sir, from head to toe examination, we should look for pallor.
Okay. You know, particularly you will check for cyanosis or clubbing because you know parents may not, suppose mild cyanosis, they may not complain. They may not complain. But I would like to check. I would like to check the SpO2.
Right.
Whether this reality is normal or indicating some cyanosis may not be. If really clear cyanosis, it will not miss it. But many times every patient may not be having the clear cyanosis. So I would like to check with the nowadays SpO2, which was not available to us, but now you can. You can check even for the clubbing. Then you may get even something else. So that's the thing. Then peripheral pulsations, you know, in a case of homocystinuria, you may get something else. Even aortoarteritis syndrome, you may get something else. So therefore, peripheral pulsations, blood pressure, SpO2, clubbing, all the things you will check in general examination. Even some nutritional deficiency, like even the anemia, very good. Okay, now on CNS, Harishma, what you are expecting? Harishma, you can take it. On CNS examination?
So patient will be conscious, oriented.
Yes.
Or memory we should check for memory will be intact, speech will be intact.
Right.
Speech will be affected if there is parietal lobe is affected. Most likely, speech will be intact
Right.
and articulation will be intact.
Very good. But you know, facial nerve can create any problem with the speech?
Yes, sir.
Mainly articulation, not the central problem, right?
Yes. Yes,
okay. Okay. What else? Some higher function. Then what you will get in the cranial nerves involvement?
Sir, seventh cranial nerve will be involved.
Yeah.
All other cranial nerve will be
Rishma, you
normal.
can make, you can make the comment in this way that seventh nerve will be there, but I will verify whether it is really
Yes,
upper motor or lower motor neuron type of lesion. That you will, because you know that clarity will be there on examination. Fine.
Yes,
and the rest of the cranial nerves you are not expecting, but you should check it.
Yes, sir.
Okay, fine. Now motor system, what you are expecting?
Excuse me, sir.
Examination of motor system, what you are expecting? What will be positive findings?
Sir, since it's a long history, there will be wasting of muscles might be present. Atrophy of muscles may be present, sir.
Okay. In how much time you will get the atrophy? Atrophy, that means only generalized or left side? Because the weakness is
left
on left
side.
side. Okay.
Left side.
Why are you expecting? Is it upper motor or lower motor?
Sir, usually element type may
yeah. So do you expect in these patients?
No, sir. No, sir.
That's why unnecessary you should get into trouble in the exam.
Yes,
very simply you can ask what will be the muscle tone, what will be the power.
Tone will be muscle tone will be a hypertonia, sir. Spasticity will be there.
Yeah, you are expecting some hypertonia, maybe spasticity.
Yes,
power depends upon the weakness that you would like to check it. Maybe third, even the power grade 3, more than that, less than that, anything can be there because the recovery phase might be improving. So that you can check. Then what you are expecting on DTR?
DTRs will be exaggerated, sir.
On which side?
On the affected side.
Left side, affected side. Good. Then what else? Sensory system probably are not expecting much. Signs of meningeal irritation, neck stiffness, Kernicks, whether you are expecting positive or negative?
Negative, sir.
Okay.
There is no history of infection, meningitis,
very good.
as per history. Sir.
Very good. Are you expecting cerebellar signs in this patient?
No, sir.
So cerebellar signs are not. Then the skull spine, are you normal or having some problem?
Mostly normal, sir.
Normal, yes. And gait?
Gait will be, since the patient is in progressive phase, circumduction gait might be present.
Yeah, if she is able to walk, probably it should be circumduction gait. You know what actually I want to bring to your notice, without examination, you can make up your mind that this should be my findings as per my thoughts. By chance, findings are different, then think something else or try to find out the probable explanation. Probably what your CT, MRI should not be able to answer, or clinical examination, precise history and clinical examination will be able to answer. And therefore, here I think just repeat, if I repeat it, Harishma described very nicely, child should be probably conscious, maybe some emotional disturbances. Vitals I will check, mostly normal. Probably except the 7th now I may not get anything positive. Nutritionally may not be bad. And if I go for the CNS, probably higher functions okay, 7th of palsy, left side hypertonia, DTR exaggerated, left side plantar should be extensor, signs of meningeal irritation absent, cerebellar sign should be absent, skull spine normal, and if she is able to walk, circumduction. And probably other system should be normal. You know, these are the things which we can decide. Now let us see. I think we have done the good job, good academic discussion. Now, Shubhi, you can test our, I will say, findings. describe it. I think now your job will be very easy.
Yes, sir. Sir,
Arishma, I think you should be happy. She has mentioned child is conscious. So you're absolutely right. Okay, take it further.
so starting with the general physical examination, the child
Yes.
was conscious, lying comfortably with an IV cannula in situ.
Right.
The vital parameters were stable. She was afebrile with a heart rate of 80 beats per minute, respiratory rate of 24 per minute, oxygen saturation of 97% on room air.
Right.
Peripheral pulses were well felt. They were regular and of
Shubhi, I will really appreciate you that what we said, even you have checked the peripheral pulsations. Very good.
Yes, sir.
Good.
And they were of normal volume, and blood pressure was 92/64 millimeters of mercury,
That
which
means
was
normal, not hypertension.
appropriate for her age. Yes, sir.
Good, good.
There was no pallor or icterus or cyanosis or clubbing or edema or any lymphadenopathy.
Good.
No trophic skin changes were there. There were no neurocutaneous markers or dysmorphic features. And spine was also normal and no deformity was found.
I think before you go further, let me ask, Deepak, are you there? Deepak? Deepak, quickly. Yes. Deepak, why she has mentioned the trophic skin changes? Or in which condition it may happen so?
So the trophic skin changes she might have taken history in view of some nutritional disorder.
Very good, very good. You know, chronic neurological condition, you may get even the trophic ulcers. I think if you remember the surgery we were taught.
Yes.
With the peripheral, even some problem, syphilis and all even the trophic ulcer, right? And that can be even the vitamin B12 deficiency also. Okay, she had mentioned no neurocutaneous marker. Why she had checked neurocutaneous marker? Having this problem of, I will say, left side weakness.
So some neurocutaneous syndromes are also associated with demyelination.
Very good, very good. Even the demyelination or even the vessel involvement. Can you give one example where the neurocutaneous syndrome presents with vessel involvement, vascular involvement? Deepak, you must be knowing at least neurocutaneous disorder. You can just mention some names, then I will guide you.
So neurofibromatosis.
Neurofibromatosis, very good. You know neurofibromatosis type 1, type 2.
Type 1 and type 2. And
NF1, what we say, and what is the NF1? What is another name? Tuberous sclerosis. Right, neurofibromatosis, tuberous sclerosis. Then, as somebody has mentioned, even the Sturge-Weber syndrome, yes, it can present. Then, even Wall-Lindu disease, they can also. So, at least neurocutaneous disease are known to involve the vessel. So, very nicely she had mentioned it should be checked. Dysmorphic features. Deepak, what is the idea of dysmorphic features?
So, dysmorphic features in keeping in mind some syndromes associated.
Yes, very good. Can you give one example, the syndrome which presents with this type of the vessel involvement or the neurological stroke-like picture?
Some
already we discussed.
Mitochondrial disorders.
Yeah. You know, even the homocystinuria we discussed.
Yes, sir. Sir, homocystinuria can.
Yeah, it is the Marfan-like manifestation. Yes, Arishma mentioned, very good. Homocystinuria will be always tall, Marfan-like. That will be the dysmorphism. Then even, you know, Moya can also have some Melas-like syndrome. They can also having some dysmorphic. Maybe even some other, I will say, conditions also syndromic. We may not be able to recollect all, but to rule out any syndromic condition. Very good. Spinal, no deformity, crackpot sign. Good, good. Okay, take it further, Shubhi. Shubhi, you are muted. Unmute yourself. Yes.
So coming to the anthropometric assessment, it showed that the child's weight, height, and head circumference were all around -1 standard deviation per age, and weight for height was also around -1 deviation. 1 standard deviation. Overall, it suggested that the child is mildly undernourished, but within normal limits for her age, and the growth parameters do not contribute.
Should be somebody will ask you with -1 standard deviation, what will be your interpretation?
Pardon, sir?
-1 standard deviation, suppose your interpretation,
Yes.
as a whole, what will be your impression regarding the growth of and the weight of the child?
So it means it falls within the normal limits.
Yeah, so say it is normal,
Yes.
right? It falls totally normal. There is no question of, I will say, malnutrition. Good, go for that. Next.
So coming to the.
I think before that, anything is missed? Karishma, Deepak, Srishti. I know some of the names because generally they were participating. Something is missed in a general examination, which should not be
Upper and
missed.
lower.
Okay, Dr. Snail mentioned upper and lower segment. Okay, but anything very important point in the presentation, preparing
Dr.
her
Snail can
PPT.
answer.
Arms, ma'am.
Sorry.
Snail, you please go ahead.
Yes, Snail, don't hesitate. No problem. What was your response?
Arm span.
Okay, span. Okay. I think that everything she takes very good, but something I will say in preparing her slide. Please, I will come. Yes,
Mid-upper arm circumference.
Garima, mid-arm circumference is important up to what age?
So up to 5 years of age, the patient
That's
is
good.
5 years of age. So
That's good. That's good. But very important point, Garima. What I want to say, Garima, growth chart she has not shown.
Yes, sir.
You can take all the way. Please to all the students, never miss the growth chart in the exam. Whatever I will say system it is ask you to examine, whether nervous system, whether CVS, Hippocampus, any system, but being pediatrician, growth chart and proper plotting and interpretation, that we should not miss. Anyway, it's all right. You can go for the CNS now because I'm looking at the time also.
So first under CNS, I examined the higher mental functions.
Yeah.
Higher mental function assessment, the child was conscious, obeying verbal commands, and oriented to time, place, and person.
Should be at what age you can assess the orientation of time, place, person in the children? Beyond what age you can do, and below what age you cannot?
So beyond 4 years of age, we can assess
good. At least 4 to 5 years. Above 5 years, certainly you can. Very good. Please, these type of questions are going to be there in the exam, so you should know. Good.
Yes. On her speech was normal with intact comprehension, fluency, and repetition, and there was no dysarthria or nasal quality of speech was also fine, and memory was intact, and memory was also intact, right? Second, coming to the cranial nerve examination.
Did you observe any emotional outbursts because which you mentioned the history?
During the examination, she was conscious and oriented, and she was following our verbal commands.
Yeah,
well.
that means it was not significant. What I mean to say, right?
So,
okay.
So coming to the cranial nerve examination, cranial nerve 1, olfactory nerve, it could not be assessed, and for optic nerve, the vision.
Why olfaction you have said could not be tested?
So we tried and we asked her.
Okay, I think you can say that 5 years difficult to get the cooperation, but otherwise 5 years you can test, right? Yes. Okay, no problem.
In optic nerve, the vision was normal bilaterally. Pupils were bilaterally equal, normal in size, reactive to light. Both direct and indirect light reflex was present, and on fundus examination, there was no papillae edema.
Very good.
With the cranial nerve 3rd, 4th, and 6th, in primary gaze, the eyes were aligned centrally, and extraocular movements in horizontal plane, they were restricted. And there was impaired horizontal conjugate movements, and with which the child compensated by tilting her head when she was asked or during confrontation test.
So what is your interpretation for the extraocular movement restricted in horizontal plane?
Sir, my interpretation is that the 6th nerve might be involved.
Right. Yes. So you can mention that on examination, even you have the point to consider that 6 now is not totally paralysis, maybe the paresis, weakness. Right. Very good.
So with the 5th nerve, facial sensation and mastication was normal bilaterally. 7th nerve, there was loss of forehead wrinkling on the right side, but eye closure was preserved. There was drooping of angle of mouth on the right side, and reduced movement of right side of the face was also noticed on smiling. Taste sensations, since she was not that cooperative, so they
Right.
could be assessed. And overall, I could interpret that this is a facial nerve palsy of right side.
I think you should mention, but what lower motor or upper motor?
Sir, lower motor is more likely, but since she
Why?
had
Because you say,
eye,
okay, loss of wrinkling on right side with
yes, sir.
preserved eye closure.
So when asked to close her eye, she was
She
able
was able to close it
to close
properly.
both her eyes. Both her eyes
But
were.
anyway, did you ask the mother whether she was able to do initial part of the illness?
So they said.
Anyway, we'll come to that point later on.
Sure.
Just you remind me. Okay, but let us complete the examination. Hearing you said normally. Good.
So in 9th and 10th cranial nerve, the palate was normal and the voice was also normal. Palate movement was symmetrical and there was no deviation of uvula. For 11th nerve, she was able to shrug her shoulders bilaterally and able to turn her head. And in under 12th nerve examination, the tongue was found central or protrusion and there was no deviation or fasciculations.
So I think from your point of view, 7th and 6th likely involved. Okay?
6th and 7th, yes, sir.
Yeah, okay. Later on, we go in the details of interpretation, but just to remember. Then what next motor?
So in motor system examination, first the muscle bulk, it was normal in all the 4 limbs and there was no visible wasting or fasciculations.
Good.
In tone was increased in all the 4 limbs, but more pronounced on the left side as compared to the right.
Okay.
In power, after assessing the power in both the upper limbs of right side and left side and lower limbs of right side and left side at each joint, what I could interpret was that power was reduced on the left side, more in upper limb than lower limb.
Okay.
And right side power was normal, and this was suggestive of left-sided hemiparesis.
Right.
Yes, sir. Under reflexes, corneal reflex were present on both sides. Similarly, conjunctival reflex was also present on both sides. Abdominal reflex was absent on the left and reduced on the right, and plantar were not elicitable.
Okay.
In deep tendon reflexes, they were exaggerated, particularly at the knee joint, but involving both the sides.
Right.
I would like to share some videos of her.
Very good. Very good. Yes, do it.
This is the first video showing the knee jerk reflex, which was found to be exaggerated.
Very
And
good. Good
all the
elicitation.
upper limb reflexes were normal. They were normal. And this video was taken just to show her facial features. We can see that there is a deviation of the angle of the mouth to the left side, which is the normal side.
But probably whether both the eyes are equally open.
So left side there is
mild
ptosis, yes, sir.
Not fully open.
Yes, sir.
That means some element of weakness should you consider?
Yes, sir, we can consider, we can say that, sir, the disease is an evolving phase, so there is involvement of eye.
Fine, but I think I will appreciate your video. Both, all the 3 videos you have even taken very appropriately, because you could show even to all the people that what is there. Fine, good. Please go ahead.
Yes, sir. Coming to her gait, the child was able to ambulate independently, although there was some asymmetry with reduced weight bearing on the left side, and there was also decreased rhythmic reciprocal arm swing, and we can see the findings in these 2 videos. While putting her weight on the left side, she has to take support. There is mild swaying of also. Some degree of circumduction at the left hip orthoid.
Yes, yes. She is keeping the wide base. Good. Good videos.
Next with this is sensory system. The crude and light touch, pain, temperature sensation were normal bilaterally. Cortical sensations were also intact. In cerebellar examination, there was no nystagmus or any intention tremors, and finger nose test was normal on the right, and it could not be reliably assessed on the left due to weakness. There were no meningeal signs, and spine also had normal alignment. Other system examination, they were within normal limits. No abnormality was found.
Fine. So I think now can you stop sharing before you go for your findings?
Yes, sir.
I think now you can see whatever the points we discussed before examination, almost the same findings are there. Am I right, Dr. Shubhi?
Yes, sir.
So I think now again some of the points which yes. Whether Shubhi, did you ask in the history? This is very important to the parents regarding the facial weakness. Was it the same at the beginning of the illness?
Sir,
Or really is there any change?
according to them, they first noticed the deviation of the mouth.
Right.
And but with time, she also started having drooling and pulling of saliva, which was suggestive that the facial weakness was progressive in nature.
Okay.
Yes, sir.
Anything else?
So while sleeping, during sleep also, she was able to close both her eyes, and there was.
Okay. Sometimes, Shubhi, what I want to draw the attention of everybody, many times in the seventh, it may happen so that, and therefore better to go in the details of the history. That parents initially may show or may complain, particularly wrinkling, they might have not observed. But eyes closing, you are not able to close, they must have observed. And initially it may be the upper motor manifestation, but usually in the due course of time when the patient comes to you, there may be some signs of recovery. And with the signs of recovery, it may create the confusion to you, whether should you consider upper motor or lower motor.
Right.
I'm not talking in this patient, but it happens so. Many times it happens. Reason is, in this course of time, facial nerve will go for recovery. And the recovery starts early in the facial nerve. Why? Anybody can explain? Why there is a fast recovery and early recovery in a case of facial nerve? For the recovery, what you advise to the patient? Dr. Sneh? Or anybody? What we advise them for any weakness? Dr. Garima? Anybody? I think there was some transient, some connection was lost. Please remember that we advise for the physiotherapy. Shubhi, are you there?
Yes, sir.
Yeah. There is a physiotherapy. And for facial now, it is a natural physiotherapy. Maximum, I will say, movement of facial muscles are taking place. Maximum, even eye closure, laughing, crying, all these muscles are working. And for that reason, it's a natural physiotherapy. Therefore, many a time the recovery phase may confuse you, whether you should consider lower motor or upper motor type of reason. Anyway, but I think in this patient, your findings were really classically good, your videos very good, and you have explained very nicely. So I think you can share your last slide of summary, and then whatever the investigations you have performed, you can show so that at least we can complete in time.
Yes, sir. So, sir, with summary, I would like to explain the summary stepwise. First is this: she is a 5-year-old with subacute progressive focal neurological illness.
Yes. Shubhi, you are muted. Shubhi, please.
Sorry. She is a 5-year-old female presenting with progressively evolving left-sided hemiparesis over a period of 2 months with associated facial weakness and behavioral disturbances. On examination, upper motor neuron type of left-sided weakness with right-sided facial weakness was found, along with horizontal gaze palsy indicating involvement of gaze centers in the pons. There was absence of other cranial nerve other than 6 and 7, or absence of any sensory or cerebellar involvement. So the presence of cranial nerve involvement with contralateral hemiparesis, this strongly localizes the lesion to brainstem and most likely to the pons level involving the corticospinal tract and facial nerve. And also the subacute and progressive course with absence of diffuse encephalopathy, it favors a structural etiology.
Right. Is there any further? Yeah.
Yes, sir. So my probable and differential diagnosis were space occupying lesions, like it could be a tumor or tuberculoma, although there was no history of any chronic systemic illness. It could be brain abscess, any demyelinating lesion like acute disseminated encephalomyelitis or multiple sclerosis, or vascular lesion like Millard-Gubler syndrome or brainstem infarct or cavernoma.
I will say, for the sake of time, just should be I draw attention, better to keep the first possibility vascular lesion.
Yeah, okay, sir.
Because you know the space occupied lesions are not expected to present in this way. By chance, if you get in neuroimaging, it's a different story. But still, I will not consider it in my clinical diagnosis. Second, even demyelinating lesions also possible. Multiple sclerosis is known. ADM usually not in this way, but still even they are known. So you can demyelinating lesions, you can keep. Vascular demyelinating, I will say, and better to avoid even the space occupying lesions in this type of the presentation. Okay. Do you have any investigations?
But sir, if she has history of 2 months, can we still consider vascular lesion? Because although they are acute and progressive, but she has
they can, I will say, slowly progress. Yes, it can be tuberculosis. It can. Or even some slow virals also can present in this way. Possible. Reason is, suppose space occupying lesion, by 2 months, we are expecting more manifestations. Initially, probably may not. Second thing, even the demyelinating, by 2 months, either the recovery or waxing and waning picture is common. These types of progressive lesions is less common. Anyway, ultimately, this is our clinical thoughts. Probably in neuroimaging, even you may get something else. It is quite possible. Okay. Next.
Sir, I have her MRI picture with me.
Yeah, please, you share with us. We can learn. Yeah.
So
okay, you got this brainstem glioma. But as I said, should be in this, suppose if I am appearing in the exam, I will not put even this space occupying lesion or brainstem. You can put in this way safely if you want to put it. Maybe some small lesion and probably may not have the manifestation of raised intraocular pressure. And gliomas usually small lesions. They may not have it. I agree. But another thing, even, brainstem glioma are very fast, progressively, even I will say very fast developing. Deterioration is very fast. But slowly progressive, I will say brainstem glioma, it can be there. Okay, anything else?
No, sir, this.
Can you stop sharing? We have to end over here. What actually I will draw the attention of all the students, that in spite of your neuroimaging diagnosis, suppose somebody has informed you, or if you are knowing, please, you should not be misguided. And second thing is the exam, because it may not be the convincing, even you may not be able to explain on the clinical ground. So in the exam, don't invite the trouble by considering or bias, I will say, neuroimaging diagnosis. We know that in our medicine, what totally we diagnose clinically may turn out to be something else on further workup. But that, I will say, happens very few patients. Most of the times our clinical diagnosis are going to be right. I think because at 8 o'clock there is some other program in the IAP, we may not extend our time. We will end over here. But let me appreciate all the students, particularly the presenter, Dr. Shubhi. I will say prepared the case very nicely. Her presentation, I will say history, examination, everything were quite appreciable. And all the students, I will say very nicely they participated. I will say starting from even most of the students, Deepak, Karishma, even Dr. Sneh, even initially Dr. Bablu was also there. So many students, I may not be able to name everybody, but certainly good. And of course, I understand that this credit goes to mentor Dr. Anjali. Dr. Anjali Parani, she is a mentor for this today's case. And I'm sure that she must have taken a lot many efforts and the pains to prepare, I would say, motivate the students for preparing this type of the cases, and even all the students participated very nicely. So
thank you so much, sir, for this encouraging discussion.
No, certainly, madam. I understand it's not the easy job. That to even motivate the students to even find out the good case for the discussion. We can also learn that which looks like vascular lesion, but yes, on the neuroimaging can be the very small progress, slowly progressive, and gliomas are known to present in this way. Certainly, and it is, I will say, learning for all of us. So I will say selection of case, way of presentation, discussion of all the students, and for that reason, I will say credit goes to Dr. Anjali and even the whole department. I understand that the whole department must have taken the interest, and that's the thing that how all of us learn even. And certainly, I would like to appreciate even that all the teachers. Even we know that our IAP in the past, Dr. Yogeshwari, when he was secretary, even every time he will see that these things are going on. Even our present, I will say, office bearers, our
sir.
President, Madam Dr. Neelam, Dr.
Madam.
Ruchira, even
Yes,
they remain present, at least that the thing had been started appreciately.
Yes, sir.
And that means everybody is having, I will say, putting their efforts in this type of the learning session, and certainly we are grateful to all of them. And
yes, on behalf of all the postgraduate students, I would like to thank you, sir, for guiding us with such finer points of history, examination, the approach to a child, and making it so simple and in such beautiful language you explain. I think all the students are greatly benefited from today's discussion, and we are indebted to the entire IAP team for organizing these sessions. Thank you so much, sir, for organizing
Very nice. Even Dr. Arif, I think, he must be approaching some institution and teacher, and I will say that also requires, I understand, lots of the efforts. So everybody, I will say, taking many pains to go for this type of the learning sessions. So
thank you, sir, for appreciation, but it is all, we all work together in, and you and whole of our people are the driving force for doing such activities, sir.
Thank you.
So Dr. Baldev Prajapati, sir, is the key person in the any PG teaching program, sir.
So I would also like to thank our head of the department, Dr. Nirbhay Mehta, sir. Actually, he is the real motivator behind all this. He only advised to select a proper case and how to prepare. He had put a lot of efforts.
Right.
I would also thank Dr. Prachi Chaudhary ma'am and other guides, which I may not be able to enlist everybody, but everybody has.
But Dr. Anjali, let me mention, I know all these are faculties from Indore. I'm visiting frequently.
I remember.
I know Dr. Nirbhay Mehta even very closely. All the faculties, even from other institutions also. And I know this is a very driving force for the students for this type of preparation and presentation. So thank you very much. And I think, these type of the, I will say, ideas and thoughts generated for the learning, that's, I will say, role of the IAP. It reminds me, Dr. Anjali, that we want to convey Madam Dr. Neelam Mohan's, I will say, mentioning that why everybody or any person should be member of Indian Academy of Pediatrics. Please send your, I will say, feelings to office, and Madam has declared some prizes. Those who are, I will say, responding very appropriately, that what benefits you are going to get it from becoming a member. Just getting the journal Indian Pediatrics, or knowing the, I will say, politics of IAP, or really the so many academic programs from IAP.
She had given a lot of clues in her presidential talk.
So I think, and whatever you perceive, whatever you feel, please send to the office, or even Dr. Ruchira, or to the office, and they are going to, I will say, decide the prizes. Prizes, I will say, different story, but they want to learn that what actually the members feel, that what is the importance of Indian Pediatrics in our learning. Thank you very much. We'll end over here. And good night to everybody. Next Tuesday again we'll be there with some new case. Thank you and good night. Good night.
Thank you, sir. Thank you. Good night.
Yeah, good night. Dr. Arif, you can take it, I will say, for closing remark.
So I thank you, Baldev Prajapati sir, and I thankful to the Neelam Mohan madam, Ruchira madam, and Dr. Singarvelu sir, Dr. Yogesh Parikh sir, and all the office bearers who had joined, and all the residents and the faculties have joined for this lecture. Thank you. Thank you, everyone.
Thank you. Good night.
Thank you, Arif. Thank you.
Thank you.
Good night.